Okay, so welcome everyone to our June webinar. My name is Kate Fassbender. I'm the Ministry Program Manager with the Association of Catholic Mental Health Ministers. I'm also your presenter today for this month's webinar on dementia and mental health ministry. So I'll just give you an overview of what we're going to be doing today. I'll give you a little bit about my background. You know me in this role as Ministry Program Manager, but I also have a role in dementia and aging. So I'll share a little bit of that background. We'll then go into an introduction of dementia, so we have a foundation to build upon. Speak about the mental health concerns of those living with dementia and their care partners, and what you as mental health ministers can do to accompany them on their dementia journey. And then I'll share resources, and we'll also have time for some Q&A at the end. Since I am working solo today, I won't be able to address any questions while the webinar presentation is in progress, but I can look at them once we get to the Q&A section. All right. So this is me, Kate Fassbender, the creative gerontologist. I am not normally one for titles, but this is a title that time after time after time people were giving me. So I accepted it as my title. And basically it means that I look at aging and the lifespan from the creative perspective, using both creative engagement and the science and neuroscience of aging and dementia. My story and how I got to this point, I can look back and see God's hand in working with older adults from the time I was really little up until present day. I was the one who, as much as I love to play on the playground with my peers, I'd rather be at the picnic table with the grandparents to listen and to hear their stories. I, in sixth grade, then began to start volunteering in aging and dementia. We were learning about Alzheimer's in my science class in sixth grade, and I decided that this was where I was going to have my ministry service project focus. And I always thought that it would be a part of my life, but in volunteer form. I never saw it as a career for myself because I thought I'd flunk out of med school. I didn't want to be a CNA or an RN or a care administrator. So I didn't think there was a place for me at first. And then halfway through my time in high school, my grandmother was diagnosed with vascular dementia. And it was at this point that I saw the journey of dementia, not just from a textbook or from a brochure, but from the real life perspective of the losses and the pain points, but also the joy. And this led into my professional work, where I ultimately got my undergraduate degree in art therapy and furthered my studies in drama therapy and music therapy, working in creative elements in care communities, and ultimately branching off into my own work. And there was elements of ministry throughout all of this, wanting to respect the dignity and the beauty of faith and dementia when a lot of people were removing themselves from that. Right. Oops. Okay. So what is dementia? I pulled this top definition from the Mayo Clinic because I felt it best described what dementia is. And so I'll just read it. Dementia is a term used to describe a group of symptoms affecting memory, thinking, and social abilities severely enough to interfere with your daily life. It is a specific disease. It isn't a specific disease, but several diseases that can cause dementia. So let's see here. Some people are saying the slides are not advancing. Let me see what I can do here. This seems to be a common problem, and Zoom is always changing how this is done. So just one moment, I'll kind of Can you, if you put in the chat, can you see the what is dementia slide in this format? Yes, you can see that. Okay. So maybe we'll just have to move from this place. I'll try to keep an eye on the chat for any issues that come up. And so what this definition and why I like it so well is it tells us that it is more than just memory. It encompasses a wider range of progressions that we see physically, mentally, socially. And it reminds us that dementia itself is also not a diagnosis. So dementia is an umbrella term. And on the next slide, I'll kind of go over what those types of dementia are. But it is an umbrella term. It cannot be a diagnosis itself. And this can sometimes be confusing because we so frequently hear and professionals use the term Alzheimer's and related dementia, kind of splitting the two, when in fact, Alzheimer's is a type of dementia. It's the most common type, but it's not in its own bracket. It's under the dementia umbrella. At the current moment, we don't have a cure for dementia. There's a lot of people working towards that, but we have yet to find it. And there's a strong possibility that in the lifetime of anyone alive today, we won't see a cure. But there are things that we can do to help them have a higher quality of life, both the person with the diagnosis and the care partner, and things that we can do to alleviate symptoms. Teepa Snow, who's a fantastic dementia educator, frequently says, until there's a cure, there's care. And that is what a lot of us are trying to do. And that's what you as mental health ministers, you can be a part of that care journey for individuals on this dementia journey. When you meet one person with dementia, you meet one person with dementia. Does this sound familiar? We use it a lot for a lot of different areas of our life. And so while you may have two different people living with vascular dementia, they're going to have very different experiences, different length of time living with the disease, different progression. There'll be a common thread, of course, but they'll be very different. And so we can't cluster people based off of what type of dementia they have. And not everyone will be diagnosed with dementia in their lifetime. There's kind of this thought process that dementia is automatically going to happen with old age. Well, normal aging is different than dementia, and there will be people who will never be diagnosed. There's a common phrase that's used to help kind of differentiate normal aging versus dementia, and that is normal aging is, I forgot where I put my keys. Dementia is, I have my keys, but I don't know what to do with them. I don't know how to use them. I don't know what they're for. So there's a difference there. Because forgetfulness, I mean, all of us, even I in my 30s, forget things like that. Where did I put my keys down? And so that is not necessarily an indicator that someone has dementia. And like I said before, it is more than memory. It's a full body. You know, sometimes we see people at the later stages of dementia, and you might see them in a wheelchair, almost curled in on themselves. And that is because it's happening more than just in the memory, but in the full body of the person. Okay. So this is the slide I was referring to in the last one, the types of dementia. So dementia, again, is that umbrella that all these other diseases fall under. So dementia helps give us a list of symptoms to look out for. And then the diagnosis are, what are those symptoms and how are they going to progress? And so we have Alzheimer's disease, vascular dementia, which is what my grandmother had, Lewy body dementia, frontal temporal dementia. We have others. I mean, there's a long list of other dementias. And then we have mixed dementia, where someone may have one or more types of dementia present in their brain. So they may have Alzheimer's and vascular dementia, very common. And so to kind of break this down a little bit, Alzheimer's makes up about 60 to 80% of the cases of dementia. And the reason for the big span in there is because there are a lot of people who misdiagnose dementia. They label everything as Alzheimer's just because we have a significant shortage of gerontologists or geriatricians, excuse me, in this country. And so there are a lot of doctors that don't fully understand dementia, but are still diagnosing it and frequently misdiagnosing it. And it is a progressive brain disease. And there are two sort of categories. You have early onset, and then you have regular Alzheimer's. Now, early onset does not mean they're in the early stages. Early onset means they were diagnosed before the age of 55. So you have kind of two categories there. And this is where you are seeing those plaques and tangles, excuse me, that are so frequently discussed when it comes to dementia. It is also where you see, the images of a normal brain and then a brain with dementia. That's typically an Alzheimer's brain that you're seeing, where it's shrunk in size and it almost looks like Swiss cheese. That is what Alzheimer's kind of does to the brain. And then you have vascular dementia, where it's more from the blood flow to and from the brain, where there's been a decrease in oxygen, which then impacts the brain. It was frequently referred to as post-stroke dementia. In fact, that was how it was originally referred to, because a lot of people who have a stroke end up with vascular dementia. It is also common in people who have had chronic high blood pressure. It can do the same type of damage to the brain. And in my experience with my grandmother, communication remains pretty solid, but it can start to diminish. But the path, because it's more cardiovascular, it is a little different than some of these others that we see. And then we have Lewy body dementia, which is kind of a partner of Parkinson's. It's the same sort of thing going on in the brain, just depending on the location and the quantity of what we call these Lewy bodies, which are little proteins that are causing damage to the brain cells. And in Lewy body, we typically first see hallucinations and issues with sleep, decrease of sleep. And these hallucinations are not necessarily visual. They encompass all the senses. So someone may be feeling something that's not happening, or hearing something that's not happening. It's not just the visual hallucinations. And then we have frontal temporal dementia, which takes place right here in the frontal lobe, and then kind of behind here, behind the ears in the temporal lobes. And this occurs, there'll be damage to those areas, and we frequently see a switch in personality. So someone who may have been known to act in such a way now may be acting completely different. Their personality may be changed. Sometimes it's not super drastic, but you will see that change. It typically is diagnosed younger than some of the other forms of dementia, and communication is lost earlier on in the disease. All right, so then kind of looking at the care partner, and this is where you as mental health ministers, you will most likely be serving the care partner more than the individual living with a diagnosis. In the world of dementia, we call them care partners, not caregivers. In the UK, we call them cares, but it's similar. And it really stemmed from those living with dementia wanting us, as those not living with dementia, to see it as a partnership, because you can still live well on your own, in your career or in a new career that you discover after diagnosis. And so it's not necessarily always receiving care, it's a partnership in care. And at this point, in 2015, I wasn't able to find a solid number for 2020, but I'm sure it has gone up because of the pandemic. 85% of Americans living with dementia are living at home. Now, this kind of breaks that thought that everybody who has dementia is in a care community or in a memory wing, and that is simply not true. And because of this, we have a lot of care happening in the home. And so we have 16 million Americans providing unpaid care to those living with dementia. And that can be a spouse, children, other family, friends, neighbors, and that can also be professional carers that come in to provide either medical or non-medical care for some fee. And we see a kind of a parallel decline in care partners from those living with dementia in both mental and physical being. There's an increase in depression, increase in anxiety. If they had a previous mental illness or mental health concern, that has magnified through this process. And so that is why it is important that you as mental health ministers also view this as part of your ministry. It's not exactly what you might be doing, but it can be incorporated into the work that you do in your ministry role. And so the care partners are feeling a lot of the same losses as a person with dementia. There's isolation, there's stigma, loss of social, financial, physical, and even spiritual well-being because of the demands of care and whether they were set up, able to accept, in-home care or respite care or things of that nature. And many care partners, in fact, I've yet to meet a care partner who doesn't also carry a lot of guilt. There's a lot of guilt when it comes to breaking promises. Oh, I promised my loved one I would never put them into a skilled care community. And they did. They had to for the well-being of both of them. Or care partners wishing that their loved one would just die in their sleep because of the drain and the pressure and all that goes on. There's guilt then that's associated there. And then there's guilt after the person dies, wondering, I should have done more. I could have done more. And so in that guilt, that then heightens the other mental health concerns that they may have. So for you as mental health ministers, of the changes that go on with dementia, communication is going to be the most important for you to understand and to kind of think about in how you approach. And so the first thing that we need to remember is that behavior is a form of communication. It's not just screaming and yelling or wandering for the sake of it. It is them trying to communicate something to you that they can't otherwise, because they can't always have a conversation the way you and I would sit down and have a conversation today. And so anger, hunger, all these things are going to be expressed in various different ways, not just through verbal communication. And so a way to enter into a conversation or communication, enter into a relationship with those living with dementia, it's best to use the principles of improv. And now, if you're not familiar with improv, the principle is yes and, meaning you accept what they tell you or share with you and you build upon it. An example of someone who was at that stage where they still had some language, but not exactly, was a few years ago when I was still working in a care community. And I walked in to greet a resident and she was on the floor. Now, my first instinct was she had fallen. I am not medical care. I need to find somebody who is medical care who can help her back into her chair. But before I jumped to that conclusion, I asked her, I introduced myself. I asked her how she was and what she was doing. And she said, I'm on a beach. And so instead of fighting saying, oh, you're not on a beach, I sat down on the floor next to her and I said, isn't this lovely? And I opened up a conversation. I said, yes to that, we are on a beach. And I opened up a window to understand where she was, because those living with dementia are also in a both and time frame. They are both fully present in ways that some of us can't even comprehend, but they're also fully in the past. And we don't know what that past is. Is it when they were 8, 20? Was it just last week? And so by saying yes to what they offer you, verbal or nonverbal, and building upon it, we can enter into relationship with them instead of jarring them out of their reality and moving them into ours. And so One of the books that, if this is something that you want to just learn more about, there's a book, I think it's like you can get it for $13, $14 on Amazon, is Start With Yes by Kathy Braxton and Tammy Newman. It's a fantastic short read. You could probably read it in a matter of an hour, hour and a half. And it'll show you ways that you can have, you can apply improv skills to your communication skills of those living with dementia. It's a fantastic book. And I'll send out a list of all book recommendations in the follow-up email after this webinar. It's also important to know that not everybody will lose their verbal communication. There will be decline in short-term memory, but we won't all lose verbal communication through the dementia process. But either way, somebody living with dementia does not always know, because of that both and time that they live in, they may not always know how to respond in a given moment, but they want to keep it together and, make sure that they are in the social graces that they have been accustomed to. And so they will read and mirror your body image. And that is your first point of communication with them. So if you walk into a room, arms crossed, grouchy, whatever it may be, skull on your face, even if they don't necessarily feel that, they will mirror that. And so even when you may not feel like it, it's best to start that moment with them by opening up your body language and smiling, because they will then mirror that, opening up a window for conversation. We also must remember when we communicate with them that because short-term and long-term memory is not something we can always rely on, that there's emotional memory that dementia cannot touch. And so to kind of use that common quote, people remember how you made them feel, not necessarily what you said. That's very true in dementia, and that should almost be a key mode of thought when you're engaging in a relationship with somebody living with dementia. And I also like to add that there's a spiritual memory. People remember the faith. They remember that they're a child of God. And so reminding them through your verbal communication also will do beautiful things in their lives and helping them find a certain amount of peace through their dementia journey. And so before we move on to the kind of how your role can look in dementia, it's important to remember that it is more than the doom and gloom narrative. We have some care organizations and other dementia organizations that like to push that narrative for both the care partner and the person living with the diagnosis. And it is more than that. There's also joy in dementia. There are gifts in dementia. And sometimes they just need somebody to recognize that, to pull that out. And in doing so, you're helping reduce the stigma, the guilt, and you're alleviating some of those mental health concerns for both the care partner and the person living with the diagnosis. Someone asked if this presentation will be available. Yes, I'll send this plus more out in the follow-up email. So this really is where a mental health minister comes in. It's in the formation of a care team. So frequently when somebody is diagnosed with dementia or is in that process of diagnosis, they build a team, knowingly or unknowingly, of doctors, psychiatrists, nurses, and CNA staff, the medical care, activities, cleaning, social support, the non-medical care, family and friends, neurologists, cardiologists, and other specialists. But not everyone might think of clergy, spiritual directors, and mental health ministers, but they are a key component to a well-rounded care team. Because your role, while it's not prescribing medication or making sure somebody is bathed or getting to their doctor's appointments or that sort of thing, it taps into a frequently forgotten element of our life when somebody has the diagnosis of dementia. And that is a spiritual component. And we here as a group of Catholics understand the beauty of our faith and how important it is. I sometimes like to say, imagine if you were told you could never attend Mass again, if you could never participate in your parish life. That loss is pretty significant. And so you belong on their care team just as much as the doctors and the neurologists and all these other people. And so you have a place on their care team. So mental health and dementia. Unfortunately, we have a lot of people that act as if once a diagnosis of dementia hits somebody's medical chart, all previous mental illnesses and mental health concerns go out the window. And that is simply not true. They may look different now that dementia is present, because dementia has a way of kind of deteriorating the filter that we all have in terms of how we engage with people and act and that sort of thing. And so the mental illness may look different than it did pre-diagnosis, but it didn't go away. And so they need you as mental health ministers in the same way now with dementia as they did pre-dementia. And in fact, the diagnosis of dementia may increase their depression and anxiety even more so. We have statistics, about 40% of those diagnosed with a form of dementia experience significant depression. And that depression is often only addressed by giving medication. And we know that medication and dementia don't always mix, especially if you have a doctor who doesn't really know what they're doing, or a care team of doctors that don't talk to each other. And so what you as mental health ministers can do is provide that non-pharmacological care for them, not direct care as we think of daily tasks, but that spiritual care and support. And research is currently looking at if previous diagnosis of a mental illness leads to dementia. I have come across conflicting ideas and research reports, so I don't have a definite yes or no for you, but that is something that is being explored. And so therefore it's something that maybe we should keep in the back of our mind as mental health ministers. And 20% of those 65 and up experience a mental illness. So that encompasses people living with dementia. And these are just that we know of, because while dementia can impact anybody, I mean, there are people as young as mid-30s or late 20s being diagnosed with a form of dementia. It's not just in our elders. Because the majority is that generation that shoved mental illness under the rug, that didn't talk about it, that didn't seek diagnosis or support. We have a lot of undiagnosed, misdiagnosed mental illness that is now blending with dementia. And so just to be aware of that and see how you can best navigate that as you enter into a relationship with somebody. And while depression is the most common mental health concern for those living with dementia, both the diagnosis and the person with the care partner, anxiety is second. And in some ways, that's very, very understandable. So what is the mental health ministry's role in dementia? Frequently, and for most of you, your biggest role will be helping serve the care partner through spiritual support groups, through mental health and dementia literacy, and through just accompaniment, being present for them while you happen to be at Mass together or at a parish event. However, this doesn't mean that you should exclude somebody living with the diagnosis. They too can be a part of your spiritual support groups and your other programming and ministry events. But while you do this, keep in mind the scope of work. Just as you do in terms of you are not clinicians, you are ministers, it's the same here. So I recommend keeping a referral list for clinicians who might also understand dementia. It's great if you have a music therapist or other creative arts therapists in your community to have them, because those will be your most influential and impactful clinicians for this population. Having spiritual directors, having other people, just like you have a referral list for the people you are currently working with, having one that also has an understanding of dementia is going to be beneficial, whether it's kept at the parish office or in a Google Drive that all the ministers share, whatever it may be. To have that is going to be something that will be a useful guide for you. So some things to think about, kind of what I mentioned earlier, the mental health needs pre-diagnosis. This again doesn't change when that dementia diagnosis hits their chart. And so if they, at one point found out and realized that they were diagnosed with anxiety or depression, that may intensify after the diagnosis, and that you should still address it as you would have before, maybe just changing your communication patterns. Another option, because ministry can be overwhelming, especially if we don't have a lot of ministers working in the church. If you have a ministry for the sick and homebound, see about partnering with them, maybe doing a joint program on dementia literacy, or seeing if you can partner up when you do home visits for certain parishioners that you think would benefit from having you there as mental health ministers. This is not an addition to what you are already doing. It's just kind of a reframing of what you're doing. So what makes a strong mental health minister? Of all the things, of the education, of accompaniment, companionship, all these tools that you have built and cultivated are also what are going to make you a strong dementia minister. Having an education in dementia, this is a great start, our webinar today. And having that referral list and doing those things, will also make you a strong dementia minister. And because a lot of parishes can't add another ministry to their parish offerings, you can fill the shoes of that ministry in times when it arises with your parishioners. We need to remember that dignity does not diminish with the changes of in our neurological condition or in the person's physicality. So putting, their dignity is not erased when suddenly their short-term memory is not there, or when they no longer remember who you are, even if you have been friends for life. Their dignity does not diminish. They are still a child of God, and they are still beautiful and still have things to offer if you're willing to accept it. The stigma is a strong decision maker for those living with dementia, especially if they also had a previous mental health concern. They now have dual stigmas going on. And so a lot of people will determine whether they keep their diagnosis private or share it freely with others. And so as you work with parishioners, this is just something to kind of keep in mind. Some people may want to come to your spiritual support groups or other events and have dementia, but don't necessarily want the entire group to know right away that they have dementia. And so respecting that, but still inviting them in and working with them again with those communication skills that you build through kind of understanding improv, yes, and they can be a part of your spiritual support group for a length of time, maybe not through their whole journey with dementia, but certainly post-diagnosis for a while. Another thing to add here is that, through dementia, it's important that they understand, or that you understand, that what's not important is that they remember your name, your purpose for why you were there, or how they know you. What's important is how you made them feel. How were you welcoming to them? Did you sit and listen? They will remember that. And so don't get caught up necessarily, although it can hurt if someone who always knew you suddenly doesn't remember who you are. It can hurt, but that's not what is important in this stage of their life. What's important is that they know that you are a warm and welcoming person, and that you are bringing Christ to them through your ministry and through your time together. So during and after diagnosis, for somebody, there's going to be an increase of depression, fear, isolation, and sense of loss. So much is stripped away. Sometimes career, volunteer work, neighbors, friends, even children and grandchildren may no longer come around anymore. And so there's a lot of loss. And we need to make sure that the church is not also another loss to them. And so we can engage with them and accompany them by just listening and supporting them the way you would support anybody else that you engage with in your ministry. Spiritual support groups, a lot of you have great success in your parish with those. And so you may want to think about how you can invite those living with dementia, and even more so the care partners. As I said, your primary ministry group is going to be those care partners, inviting them into your spiritual support groups and seeing, how that works. But you may also want to think about having two separate groups, maybe happening at the same time. And respecting the fact that some people will try to hide the diagnosis, either for themselves or for a loved one. But there's also people who want to have a space where they can speak about the diagnosis, about fear of stigma, shame, and guilt, which is an environment you're already creating through your ministry. You are already providing that opportunity for community without the stigma, the shame, and the guilt, and they seek that as well. So again, it's not necessarily adding another thing to your plate, but just understanding how to maybe incorporate more people into your group, or just having two separate groups, which would be a little more work, but it's not a night and day sort of situation. So during the progression of dementia, participation in support groups and ministry events may diminish. You may have seen a care partner who would always go to daily mass, suddenly now occasionally makes it to Sunday mass. For the person with the diagnosis, the brain and body are starting to show signs of dementia. It's getting harder and harder for them to conceal their diagnosis. You may just see people disappear altogether from your parish who were once active. And so there's maybe a window of ministry opportunity there. Again, partnering with Ministry for the Sick and Homebound and seeing if you can bring mental health ministry to them, or even just accompaniment and just a listening ear. Use the arts, especially music, in your programming. So you may want to develop a spiritual support group that plays some music in the background, that has elements of the arts and conversation through the arts. And that's something that could be a whole other webinar. So I won't dive deep into that here, but there are a lot of ways that can look. And also to remember that the ministry continues for the care partner even after the death of a loved one. Frequently, these care partners sacrifice nearly everything, sometimes even their home, all of their friends, their career, and they now have also dealt with the loss and the slow loss of their loved one. And so for some of these care partners, they may need you more after their loved one has died than before, and when they are in that journey actively. So here are some key ministry actions to think about. Involve those on the dementia journey into your mental health ministry. There may or may not always be a direct relationship to what you are currently doing. The journeys look a little different. Being a care partner for somebody in their 20s with a mental illness is different than that of somebody living with dementia. But bringing Christ to them, listening to them, accompanying them, that looks almost identical. So finding ways to involve them into your ministry, even if it's in small ways. Pray for and with them. Don't assume because they have dementia that they can no longer pray the rosary. Many, in fact, I've been with who've pretty much lost all form of communication. If you get them started reciting the rosary via kind of like a sing-songy voice, they can continue on praying the rosary with you. So incorporating that spiritual element into their life once more, And remembering, as I'm sure you do for all those that you serve, praying for them, praying for their families. Welcome care partners into your ministry, even if they always say no. It's the invitation there's healing in that, to know that while all other elements of life have disappeared, there's still an invitation there from someone in their church, in their Catholic community, that is still inviting them in. Because one day they may say yes. It may be the second time you invite them. It may be the 100th time you invite them. And they may never say yes, but that invitation is incredibly important. It's also important for those living with dementia in the earlier stages to continue to invite them into your ministry and what you're doing. Determine if you want to do separate spiritual support groups for those living with dementia. I think in terms of starting point for how you can incorporate dementia into your ministry, this is a fantastic thing to do, because you already have the model built. You already know how your facilitation kind of personality is. And so it'd be a great place to start that conversation and even to build awareness in your parish community. And so it's just a matter of, do you invite them into an existing group or do you create another group? And understanding that group, because of how dementia is, it may waver a little bit more in terms of the people that come in and out, in and out. And the final key action that I would recommend is complete the Purple Angel training. It is 90 minutes and it is free, and it was developed by a man who has Lewy body dementia. And so he built this education program off of his experience. And so it's frequently referred to as a dementia-friendly training, but it does more than that. We dive deeper into the training of what is dementia, but then also have a conversation about what does this really look like within our parish, knowing our parish demographic, needs, the time of us as ministers, what we can give. And that is something, there are Purple Angel trainers across this country. But if you don't have one in your area or can't find one in your area, I am a certified trainer. So you can come and get in contact with me, and I can offer that to your ministry, to the parish staff, to the parishioners at large, whatever it may be. And this is similar to mental health literacy. This will kind of provide that dementia literacy in a way that's adapted to the Catholic faith. All right, and then here's some resources. Again, I'll give you a more fleshed out resource list in the follow-up email, but My Catholic Doctor is a fantastic resource. Dr. Kathleen, who is the founder of My Catholic Doctor, has some work in dementia in her team and what she's doing. So for your back pocket, that is a great resource. The Peace with Dementia Rosary, I have, it's a book here, and it guides you through praying the rosary with dementia and all the ministries. It is a great prayer resource for you. The Hem of Christ, to me, that is my ministry that I do in addition to working for Deacon Ed and the Association of Catholic Mental Health Ministers. And I provide education and other resources in dementia and faith, really helping keep that element of someone's life alive throughout their lifespan. Caring Kind is a fantastic organization. They're based in New York, but work nationally. And that is where you can find a lot of care partner training, updated stats on, okay, how many people are living with this type of dementia, or what is the research on this. They offer all of that. Fantastic, fantastic resource. The next is Tom Kitwood. He has since passed, and so some people consider his work a little out of date. But he has written many books. This one, Dementia Reconsidered, The Person Comes First. If you're looking to really expand this element of the ministry, this is a fantastic resource. It's a little lengthy to read because there's a lot. It's small, but there's a lot there. But it's an important resource, I believe. And then Susan McFadden, who is from my hometown of Appleton, Wisconsin. this is just one of her books, Aging Together. She has done a lot of work on the community of dementia and how we live in community with these individuals and their care partners, and also in aging in general. And so that may be another tool in your toolkit to kind of have her work in the back of your mind. And then the final one is Ann Basting. She's based in Milwaukee, Wisconsin. She's the founder of Time Slips. And so she's written many books. Creative Care is my favorite of hers in terms of just recommending to anybody, whether they're connected to dementia or not. And they also have this imagination kit. And now these are secular images, so to speak, secular. They're not religious images, but they may inspire ways that you can use art in your ministry for those living with dementia. So I will send out kind of an extensive resource list along with this presentation in the follow-up email. But with that, if you have any questions, feel free to throw them in the chat and the Q&A. And if I happen to miss one, poke me in the chat and I can figure that out from there. So if you have any questions, feel free to ask them now. We are also looking for resources. So if you have done work with your mental health ministry in dementia and have created resources, please send them our way. I think we've mentioned this in a couple previous webinars, and that we're looking at making the website really a treasure trove of lots of different things that you can rummage through that can assist you as mental health ministers. And this is an area in dementia and aging that we don't have many resources. So if you've created those things, please share them with us, and then we can get those out for other people to use. Okay, one question is, could you give some alternative saying, do you remember when talking to someone diagnosed with dementia? Yeah, so you don't really want to use remember in your vocabulary when you're speaking with somebody with dementia. And so it comes down to knowing the person and the situation. So instead of saying, well, don't you remember so-and-so, you could reintroduce them. And then if there was a common story that that person had with your loved one or the person you're caring for, start sharing that story. And depending on where they are, I found even into the mid stages of dementia, they will start to kind of remember this individual, this moment, that sort of thing. But when it comes to then things like doctor's appointments and that sort of thing, I wouldn't even push it. I would just say, keep repeating, we have a doctor's appointment at 3. Mass is at 5:30 on Saturdays, whatever it may be, just kind of repeating that and saying, do you remember or don't you remember, that sort of thing. So kind of doing it as kind of connecting a story to somebody or something that you want them to remember, or just saying as if it's brand new information for them. Can you tell us a bit more about the Hem of Christ work? Yeah, so back in 2011, I started bringing communion to residents in a memory care. And I was recognizing that a lot of people would give them communion and then leave. But what they were craving, yes, they were craving the Eucharist, as that is, beautiful element and the most important element of our faith. They were also craving accompaniment and prayer. And so I would sit and pray with them. And so that kind of started a moment. And then I was realizing that a lot of care communities didn't know how to create a sacred space. Even if Mass had to be in the rec room, they didn't know how to create a space for Mass that was inviting and could uplift the spirit. So I was continuing to do that, and people were saying, oh, start a nonprofit, you should do this. No one else is doing this work. I was thinking, I don't have enough body of work to create a nonprofit. Everyone I know is starting a nonprofit. I don't want to do this. And then when I was working in a care community about 5 years ago, a woman that I was working with in a memory care was denied the ability to go say the rosary with the rest of the residents because she was a wandering risk. She was devastated. I was at the end of my shift, so I clocked out and I went back up to her and I said, I'll pray the rosary with you. So we sat and we prayed the rosary. And again, she was kind of on that cusp of communication, the way we know it, verbal communication, but she could pray the rosary. And after she was done, she thanked me. And then she started giving me basically a theology lesson. She was sharing elements of a knowledge of faith that I was just absorbing in, because some of it I did not know myself. And then the next day, CNAs were coming up to me, asking me what I did, because she, for the first time, did not fight to put her sweater on, to go to a doctor's appointment, or go down for meals, or communicate with the rest of the residents. And I simply said, I just prayed with her. I joined her in faith. And it was at that moment that I realized that there was something there that I needed to flesh out. And so it still took a while. And last year, I officially launched the Hem of Christ, which really seeks to provide those on the dementia journey with all the tools that they need to help keep the faith alive, even when the secular medical world is telling them they can't or they shouldn't. And so I provide education in just dementia in general, but also how our activity staff can incorporate elements of faith into their programming. And I do this in care communities, and I also do it in parishes. So I go beyond a dementia-friendly parish in terms of lighting, ramps, that sort of thing. But how can you, as clergy of the parish, as parish staff, as fellow parishioners, accompany those living with dementia? And so that's other element of what I do. And I'm working on developing a program that specifically accompanies care partners after their loved one has died. So that is the work that I do with the Hem of Christ. What's someone who is good Christian? I have never come across anyone starting to deny God. I think if you did happen to come across somebody like that, with dementia, it may not be best to kind of force the conversation, but you can still accompany them and maybe share your faith, share your experience, favorite prayers, ask them, can I pray for you? Do that sort of thing. But I won't try to get them to revert back, because on one level, I mean, I don't have any science or research behind this, but I have to believe that it's the dementia denying God, not their true spirit and beliefs. So I don't know if that answers your question or not. That we may have. If not, thank you for attending this webinar. I realize that I kind of went through that fast, and it really is only skimming the surface. So it opens up the conversation. And if you have questions following up, or want to learn more, or want to have a follow-up presentation, feel free to let me know, and we can work out something that we can make sure that you as mental health ministers are also able to serve those living with dementia and their care partners. So thank you very much, and we'll see you in next month's webinar.